care organization comprised of 24 critical access and rural hospitals. Following Director Schou is Rex Brown, who is the president and CEO of Hillsboro Area Hospital, a critical access hospital in Hillsboro, Illinois. Under his leadership, the hospital has been named a top 100 regional and top 100 critical access hospital and has won numerous awards from Press Gabany and the Studer Group, as well as 6 consecutive awards as a St. Louis top workplace. Most recently, Hillsboro Area Hospital, in partnership with the Department of Population Science Policy at SIU Medicine, was awarded the 2022 Outstanding Rural Health Program by the National Rural Health Association. Rex is a fellow of the American College of Healthcare Executives and holds a bachelor's degree from the University of Wisconsin and a master's degree from the George Washington University. And I will turn it over to Pat Schou.
Hello, everybody. I think you're going to put up my slides, right? Okay, good. Well, it's really a pleasure to be here and a pleasure to be with Becky and Rex and talk about rural hospitals, my passion. I must be a hospital geek because I get excited about hospital business and how it plays within our community. So this is really a very good topic for all of us, and hopefully when you finish, you'll have a little bit better insight into this. But it's great to see friends from all over the state and on with the show, so to speak, right? Anyway, as TJ said, that our job is to talk today about the role of the rural hospital within the community. So, see if I get this right. Oh, here. Okay. Let's see if I can get this work. If I could do the AV stuff, I'll pass here. So, is it not? There we go. Okay. All right. So what I'm going to talk about today, I'm not going to give you a lot of facts and figures. What I want to talk to you today is about the cultural change that has occurred in rural hospitals and why it's so important for rural hospitals to be involved with their communities. And you're going to see, when you hear from Rex, you're going to see the value of being involved. But I had to walk back in time when I was a nurse in a small rural hospital and wanted to talk about it because it really is a cultural change that we've gone through over the last number of years. If you sit back there and you think in the 70s, you know, hospitals really were inpatient care. You came to the hospital to have a baby. It was the emergency department and trauma, you know, there was an accident. It was very nurse dominated. You know, of course, I was coming out of the nursing school. I was all excited, you know, ready to go. And it was mostly inpatient surgery. Who ever heard of having a surgery done as an outpatient? We had limited lab and flat plate of the abdomen or a upright chest x-ray, you know, some lab work, and a few local services. There might have been a little counseling, not much. And as far as the role within the community, it was fundraising. It was fundraising. And, you know, you might have had somebody, you know, on the board that, you know, shared what was going on in the community, but mostly it was fundraising. So, okay, whoops. Sorry, here. And I think it's important, and I hope you can see this. I tried my best to bring this out, to show you the evolution of hospitals and where we came from. So if you look back in the 70s, where I can draw my evaluation of it, it was, as I said, inpatient care dominated. We had ICU units. That's really the first time ICU units. We had emergency departments. That was big time. And it was the beginning of emergency medical services and how the hospital played the role of the EMS ambulance. Because prior to that, it was the funeral homes that picked up people and took them to the hospital. So it really was a cultural change at that point. Then you moved in the 80s, and it was diagnostic procedures and scopes, and you know, we looked at the cost of healthcare emergency. I mean, if anybody had a Chrysler back in the 80s, we heard Lee Iacocca saying, you know, my car costs so much more than Japanese cars because of healthcare. And so that was the first, you know, really push on that. And then in the 90s, we moved into outpatient services, and the payment system changed. We had critical access hospitals that merged at the end of the 90s. And then in 2000, chaos happened. We had electronic medical records, and there was a slow expansion of clinics into the community that, you know, we really had, you know, rural health clinics and FQHCs really started to grow then. And in the 2010, of course, that was really a major change, whether you like the Affordable Care Act or not. it really changed the course of healthcare as far as for community and patient engagement. Because we started looking at community health needs, physicians really decided it was better to be part of the hospital system than to have their own independent practices. And then in the 2020s, we really are focusing on population health. We're having advanced practice providers, telehealth, hospitals without walls, ambulatory care programs, and really looking at post-acute care. And that's different than the first picture I showed you. So, it's important to understand where we've come from and how we need to go. So why have the rural hospital life changed, And it's simply because of reimbursement. If you remember my discussion about cars, the cost of cars, well, that's really how the government says, traditional Medicare, because patients, over 65 that are in Medicare, they can go traditional Medicare. They can go anywhere they want to for healthcare. There's a little limitation, but not with other plans. So the government knows that we have to really control healthcare costs. We've got diagnostics and internet and consumer demand. In the 70s, you just did what the doctor told you. And so you never really had choice of hospitals. The growth domestic product, what is it now? 19% is on healthcare. Whew. So you can see what's really happening. And then we finally realized the impact of social determinants of health. So you've probably seen these different models throughout the time, but I think it provides relevance to our discussion today about the culture change going on in our rural communities and our hospitals. So if you look on my left or your right, you've seen this one. This is probably a shocker for all of us that grew up in hospital inpatient business, that the healthcare costs really weren't hospital costs, but it was really behavioral and economic things that really impacted. Then you move into the middle section, which is that nice little diagram of Healthy People 2020, and it was really putting social determinants in the middle. And then if you go in the far right here, or my right and your left, it really brings in all the components that are involved in healthcare, all the different groups that we have, about the impact of language, the impact of literacy, and so forth. We never thought about that 20, 30, 40 years ago, but it's really relevant as you look at the role changing of the hospital. So this is downtown Princeton. So if anybody ever been to Princeton, Illinois, raise your hand. Yay! Anyway, there's some people back there. Anyway, so, this is what it looks like, but the economic impact on a rural community hospital is incredible, and Rex will certainly attest to that because of the local purchases. It's like a value of 3 to 1, and if that hospital closes, we know the community really decreases. We have business development. I've had businesses call me up when I was at the hospital as a VP there, and they would say, I want to bring a business in town. Can you tell me about the ambulance and the hospital system so I can tell my insurance company, so I can have a decrease in premiums? The standard of living, is so much better when you have a hospital right locally. You have EMS support, and of course, that's the opening to healthcare. So, it's really, really important, and we know that's why rural hospitals fight to stay open, because they know the impact of that community. So if you look at the role of the rural hospital today, let's jump from 1970s to hospitals today in 2020, 2022. Very little bit of our business in our rural community is inpatient, right? I remember in the late 80s when I was sitting around looking at how much to predict for business next year for surgery, they say, oh, gosh, we're going to have 80% inpatient and 20% outpatient. Now, what is it? It's like 95% outpatient surgery and 5% inpatient surgery. So, the business is really changed. It's outpatient dominated, and that's really critical access, and small rural hospitals can certainly attest, because rural programs are reimbursing us for those outpatient services. We have the focus on community groups and support groups. We heard wonderful things this morning about the school systems, about how they're trying to work with the hospitals and vice versa. Telehealth, mental and behavioral health, prevention and education. And really, the rural hospital should be focusing on the care through the life spectrum. That's very, very important, because you want people to stay locally. So, you know, when we talk about population health and we talk about the role of the rural hospital, we have to talk about the population health movement. If you go back and you think the cost of healthcare, we realize that that's not sustainable. So it's the movement from sickness to health. And this is all stuff that you know. But I'm trying to build the argument about the change of the culture and the things that we have to in rural hospitals look at today. We've got to look at lowering individual costs with diabetes and hypertension and all those things. Because, you know, when I look, we run an accountable care organization. When I look at how much it costs an end-stage renal disease patient in our accountable care organization, more than $85,000 a year. If we do a better job with diabetes control and hypertension, that's prevented. And that person obviously has better lifestyle. We need to keep the patients local. We can't have what we call leakage because you have to have business. No money, no mission. And the demographics, we have to understand our demographics. And obviously, locally is where you address the social determinants of health. So how do we learn about our community? The group before us talked about the community health needs assessment. That came about in 2012, and hospitals that are non-for-profit or government, they can do it, are responsible for their tax-exempt status. The Public Health Department has the Illinois Project for Local Assessment of Need called iPlan. We have hospital advisory committee support groups. All those things should be feeding into that hospital administrator or that board to know what services that are so important for us. Senior care, business community, you know, should you not providing contracts to your local businesses so they come to your hospital for their lab and x-rays? So there's ways that you can engage your community and then you can take care of them for back care and other things like that through the industry. The details of the community. So when you look at the community, I put some pictures together in the upper, you can see an elderly person wondering, you know, where they go. And then you look at, you know, the opioid use that we have to deal with, you know, and how a local community has that. And then the picture of the community itself, and then transportation. So when you look at the details of the community and the role of what you're going to do to fill those needs is access and public health and the outcomes and economics, just grocery stores and transportation. You know what we have in our rural communities? You know, we get in a town of 300 or 400, Casey's, that's our grocery store, right? You get your gas, you get your milk, you get your bread, you get your pizza, you know, your donuts like I like, you know. Anyway, so that's, but you know, it's more than that. Is that really all good health? All good health. You know, we did a program several years ago, and we have Sam Quinones, who wrote the book Dreamland about the opiate addiction. And he looked at me and he said, you work with rural hospitals. He's from California, sunny California, where all that population and the fun stuff is. And he looks at me and he says, because I was telling him about how in our rural communities, we have to send food home with kids from school called buddy bags, you know. And he said, how can you in a rural community have to send food home to kids? Don't you have food available all the time? So, you know, you really have to understand the economics of the community. And then the engagement, you know, you have more, it's more than fundraising. How do you engage them and how do you keep them, get them involved? And how do you hear the patient satisfaction surveys? And we heard that Rex is one of the top hospitals in the country in patient satisfaction because he listens to his community. And we want our people to stay locally. That's how they can engage. We need to hear from the community what they need and what they support. And we also look for them to help provide scholarships so we have workforce. So we have to be able to, as a hospital, to communicate. And whoever social media, you heard me ask about social influencers, but you know, we have to be somewhat social influencers. And how do we do that? And because now you're supposed to go to your patient portal, that's how I get my lab work. I don't wait for my doctor to tell me. I go on and I find my lab work. We should be a resource for information, an open door. And one hospital does a weekly radio show. I think that's great. They give them all sorts of topics. It's Warner Hospital, Paul Scourin. And I think it's great. And it's a way that the community can keep informed and keep that hospital in the center of healthcare. I think that's really important. And the other thing is the partnerships. One thing, you know, there are good things that came out of COVID, maybe just a few, but it really taught us to look at our community as a partnership and as a whole. And about pharmacy and how do we work with getting medications and law enforcement and churches and local government. So all those things, as a hospital, we have to inventory our resources. We are seeing emergent role of a community health worker. They've talked about having somebody locally to advance, and SIU and public health have done a great job of doing that. I thought I would conclude with just telling you a little bit about a couple of the hospitals, and I think that's really important. This is a hospital, a critical access hospital in Aledo, Illinois, which is part of Genesis, and they also have, on one side of the hospital setting, they have obviously acute care hospital. The other side, they have a long-term care, and they also work closely with the local health department. But how you engage in the community, this is one like Rochelle Community Hospital. Everything we do revolves around you. You know, we want your hospital to be proud of you. And these are all the things that our hospitals do that we have to play a role in, not just inpatient care from before or fundraising. It's a partnership between us and how we do that together. The community needs assessment, how important that is. You don't have to do something fancy like something that ICANN might do or SIU or whatever. I mean, you can do your own, or you can use the local health department. But the thing is that you're looking at your community. And mental and behavioral health, you know, years ago, all it was maybe counseling for alcohol addiction. We had AAA back in the 70s, but that was about it. Now we have a lot of things, senior care, we have senior outpatient psychiatric care is what I'm getting at, a lot of mental health and behavioral wellness and so forth, telehealth, podcast. Who'd ever think that we'd be doing podcasts and virtual health? And urgent care centers. You know, we never had urgent care center. I was once the night nurse in the emergency department, and people would come in, they'd have to open up the ED door for me to take care of them. Then I had to call the doctor. And this was like at 2 o'clock in the morning. And now we have urgent care centers where you can walk in our rural communities. The thing is that our rural hospitals have adjusted to the change, and they've done some wonderful things with that. Had wellness centers, walk-in community. The outreach is important. And I know they do that in larger facilities. But the thing is that our hospitals are listening, and you're going to hear about iiRHS. But our future starts with understanding where we are and what we can do, from babies to sending nurses to school, or the symbol of health. We don't talk about sickness, we talk about health. And I thought memorials was an important logo. And so I'm going to conclude. I forgot to show you a couple pictures of hospitals that now have mobile rural health clinics. And I think that's even, you know, really outstanding, that they can actually take their mobile units and they go to the schools and they have rural health clinics, and that's something that we didn't have the capacity to before. But it's about partnerships and listening to your community. So the role of the inpatient, the nurse-dominated hospital, yes, nursing's important, lab and everything, but it's the partnerships with the community that makes a difference. So I'm going to turn that over to my colleague, Rex, and he's going to talk about his partnership that he's had with his community. And I tell you, the best way to predict the future is to create it. So it's all yours. So thank you. I think they're going to take me off there, so.
Thank you, Pat. Well, I'm hooked back up again. With just a full disclosure here, I've been psychologically wounded by two of the slides that popped up. Jerry had one that had the year 1937 on it, and he wanted to assure everyone that he wasn't born then, but I was born before 1950. So these numbers that are popping up are kind of tough. And to see Pat use the hospitals from the 1970s, I'm only a couple of months away from my 50th year in healthcare. So, well, thank you for that. But I'm just saying, I've got some old stories, and I'm not going to bore you with them. But Pat's right. We are different today than we ever were before, and it's all for the good. And we've done a lot, but when it comes to mental health, I want to say that we're way behind, and I'm part of it. I didn't see what the opportunity was because of a lot of the things we heard from our excellent panelists this morning when they were saying, things like, you don't have the workforce that just drops from the sky. So we didn't have the resources, we didn't have the money. It was had to be somebody else's job to do with the mentally ill. And yet that entire time that we were doing other things and great things, and we were engaged in our community, the mentally ill were suffering. And so I got to take ownership of that. We are addressing that now, and we do have a different slide there, I think. It looks like this. Oh, I have to do that? I'm sorry. I thought they took that away from me. I had a presentation with some of the people that may be even here today, but in Champaign 2 months ago, and I kept putting my paper on the button and it kept going, so. I'm going the wrong way. There we go. Well, I sure can't read it from here, so I apologize for that. But I'm going to step you through it. It's really a flyer that Jessica here had a hand in, and see how this stuff just goes on its own. And I used it at the annual meeting of the hospital a week ago tonight to let them see what they have done, because it's a hospital situation now. I didn't touch anything. There we go. So now that the slide is up and if it's stabilized, I have a couple of other things to say as intro. One is I want to express my gratitude to the Department of Population Science and Policy. We've been working with them for maybe since before they were a department, for one. But we first started with Wiley investigating the opportunity to do something in the eastern part of the county where we had a hot spot with colorectal cancer. That moved ultimately to looking at research on lung cancer and the potential impact of lung cancer screenings. But the work with Samir began with neurosynapse development, where there's a research project out of New York, inner cities, and Baltimore, and we were wondering whether or not it could be translated into rural. And we were excited about that, because when I came to Illinois, I realized that rural was much more like inner city than it was like anything else. And so I came 30 years ago. Up until then, I'd been in a hospital similar size to Memorial, and but I wasn't the CEO, so came down just to see what that experience would be like, and that was 1973. So you can see how those years have added up. Now, for if you wanted the math, next, after thanking them for all that they have done, and what I'm going to present on this slide is really the process, and you heard this from Samir earlier, the process outlives the action. And they've put a process together and stepped me through it, and I accepted it, and that was the smart thing that I did. The first smart thing was to call Samir. The other is I've got to let you know how honored I am to be able to share the podium with Pat Schou. She's nationally known, so you don't know that, but people know her across the nation for what she has done, and she has done excellent things for our hospital. So I want to thank you for all that you've done. And Pat is so humble that it's very difficult to compliment her without her saying, "Oh, I could have done better." But she's done an outstanding job for us. So now, how did we get involved in the mental health area? Very simple. Almost a month ago, and then back about 5 years, we had a board meeting, and a board member at the end said, we have a problem, and the problem is this. Our daughter came home from school, and the kids told her she was so worthless that she might as well commit suicide. And I'm from Hillsboro. My wife is from Hillsboro, and we did not have this when we grew up. And in Hillsboro, we don't know how to deal with it. And it was a shocking thing to hear. And then someone else said something similar. And then someone else on the other side of the room said something similar. And all of a sudden, it was just like popcorn. So there we go. It was shocking to hear. It was also surprising for me to hear, because we were not doing anything in mental health. And so there is what I had confessed to earlier. And I said, we'll do something about it. And the next morning is when I called Samir. He was on his way to Chicago, as he was after his presentation here. But we chatted on the phone, and he, if you looked at his presentation, you would see where he already understood we didn't have services. Why would there be a surprise that we were having problems in Hillsboro with mental illness when there's just no services, there's no staff, there's no penetration? And he said this is going to be very difficult to turn around. But in a couple of months, he had a process for us. And that's the first thing that we have under step one. So we partnered with the School of Medicine. And the next was we started working with what I call the usual suspects, people that we would use for strategic planning and things like that. And then we moved out to the process that was being recommended by Samir and Nicole Summer Gaber, who's not here today, but the key researcher. And we set up an independent steering committee. We didn't know what to call it. They've never changed their name. They're the steering committee. And we take the role of providing resources. They decide what they're going to do with the community. And they politely allow me to be there, but I don't say anything. And it's a group of 13 people. We have a psychiatrist who is an advisor without a vote. We have a member of our medical staff who does have a vote because he represents the medical staff. But you can start to see this is kind of community, and it's not a department of the hospital. And that was one of the first big lessons that I received from the school, I'll call it, but PSP. And then the next is that we conducted an assessment. So I heard earlier, I forget who said, our children are not guinea pigs. I use something different. We're not going to test something on our children that we don't not know is going to work. This is their life. This is the life that's going to affect not only them, but their family and the community. So we believe that the secret sauce is the research. And so we collected the data. We began that process, and it was extremely successful. And then got the results. Now, by this time, we were definitely partnering with the school system, or we wouldn't have been allowed to go into the school to do this testing. So we had a partnership with the School of Medicine, a partnership with the local school district. We had partnerships with people that are on this steering committee. And we then went out and frankly, I don't have it on here, but we raised money. And so we had the money to move forward. The third step was examining the data. And of course, that's what we were all waiting for. And the data was that 1 in 5 youth thought about committing suicide. 1 in 4 youth had abnormal levels of depression. The risk factors that were very prominent in the community were low commitment to schools. Now, coincidentally, we had heard that from a physician and his nurse practitioner, both of who went to Hillsboro school system maybe about 15 years previous. And they said the kids that we see in our practice are different than the children that we grew up with. And so we had started to be thinking about that, but we, as I said, had no idea as to what to do, and there didn't seem to be any pressure, just a change. and I was just, dead in the water. So the next is bullying, and of course we heard that from the board member, and then family conflict. And so we had, three big ones right there, and family conflict meant that we were going to get into a role with parents, and I was frankly afraid of that. I thought this is just too much for us to be, without any experience, to be working with families. We looked for someone else to do it for us. Nobody could at the time. And as a result, the steering committee selected two, and it was the next, Sources of Strength, and then the Blues program. And Sources of Strength really hits on a lot of the elements that we heard in the topic presented. So if you heard something, well, maybe Sources of Strength is actually going to help adjust that. And what you get there with Sources of Strength is peers. And I've got some numbers here. We had 74 peer leaders, so students who agreed to be trained to be peer leaders. And so we have that conversation. We've opened up the realm of potential connection to people that are having problems to 74 children. One of the things that we thought was very exciting about that is they're going to be able to take that schooling and those skills on through the rest of their life. The next element is that it's adults. So its peers would move them toward adults. And now we have 20 trained adults in the school system who are able to start to handle and connect with students as they're saying, I'm depressed, I'm being bullied, I want to commit suicide. And then those adult advisors have remained in the program. The third one was the Blues program, and for that, we had to infuse skill sets from the hospital. So the money doesn't exist in the school systems, and so that was a commitment that we made to find staff that could actually facilitate that program. And the difference between the two simply, one is prevention, which is Sources of Strength, where you look for your strengths and then try to add to them, and the other is an interventional, so that's the Blues program. These are selected by the steering committee. How'd they get that? Well, we went to the School of Medicine, of course, and the PSP came up with, scoured the country, came up with 9 programs that fit the risk factors that we had, presented it to the steering committee, and the steering committee vetted them and then came up with the 2 that we selected. The third one came a little bit later, and that was the one to address family conflict, and that's called Strengthening Families, if it's dark enough on the slide. And we are just starting that. And one of the questions I'm sure you're going to be asking is, well, where do you find this money? And it's a large part is operational funds to the hospital that are being dedicated. Part is the fundraising that I talked about, and the other is grants. And we were able to get a $300,000 grant for Strengthening Families. And that is just about ready to kick off. So the next was building capacity. And we had to have social workers run the program. We were able to do that through the school. The program coordinator for all of this is an employee of the hospital. But it's very important that the principals have control over their schools. And so our staff go in there, and the simple way I put it, if the principal tells you you can't walk down a hallway, you cannot walk down that hallway. We are guests when we walk in there, and it's well understood between all of us that we've been invited in, but we do what we're told within the confines of the school. So the next is training, and I had already given you that, and then program operations, a little bit of a feather in the cap of our staff who are putting on the Blues program is the school system thought so much of the impact that it was going to have, that it was having, that they integrated the Blues program into, I think it was communications Jessica, okay. The communication program, educational program, which is a requirement in the high school, and so it's integrated. There is a option out that the school board wanted to have, so the child didn't have to go. But it's the first time that the Blues program has been integrated into a curriculum, and the Blues program is across the country. It's international. I'm going to reach this way as if that's England, but they have, I think, 7,000 students in the Blues program in central England. The next is evaluation, and I was talking earlier, and that's essential. We got to see whether or not that we're making any difference with this, and if not, we wouldn't change our commitment. We would change what we were doing and make certain that it had an impact. And so we strengthened pro-social behaviors with sources of strength, improved father-child relationships. And you heard from our panelists how important it was for better bonding between adult and child, improved feelings of making an impact on their schools and peers. So those are all great things that happened. And teachers and families would report that they see a difference with their children. But also with the Blues program, we reached 31 students and decreased depression and increased resiliency so that they knew how to act when they were being confronted with things that were really starting to make them uncomfortable. And in numbers, I think it went from it dropped from 80% to 63% on the depression scale, and that was within one class year, as I recall. Okay, so we continue on, of course. As I said, we're committed to this, and the last is growth, and we, last year, we did the same model with the Nokomis school system. They looked at what we were doing. They asked the hospital if we would help them, and we brought them in. We're spending the same amount in resources with them that are necessary to run the model. And we have a meeting tonight in Nokomis, but they are trying to have their program start in January. At least they were last month. But here's an important thing. We did the same research, same questions, and the curiosity was killing me. Is it the same problem across the country? The cell phones and social media and all the rest. Could we not have to have this research? And the answer is their risk factors are different 20 miles down the road than they are in Hillsboro. So there's no shortcutting it in my book. And so that's an important part of this, and the expertise from PCP is invaluable. And then the PCP is actually now introducing some new changes, and you heard it, and so they're even in Alton. So that is that's what we've done. As far as outreach, when it comes to rural, I want to say that our vision statement is that it starts out, we will partner with our community to continue to be recognized, et cetera. But it's that partner right up front in our vision statement. And we have partnered on many areas, the outreach, because our belief is that we are the resource for the community. We're very small. We're one of the smaller rural hospitals. Our primary market share is, let's say 8,000, but there's only 4,300 people in our primary market. So it can be done. And just think of the suffering. That might be the motivation for your community. It was for me. And the last thing at the bottom, if you can get up and see it, that's our billboard. So we have a number of billboards with our children on the billboard. And of course, the stigma, you heard that earlier. We want to reduce the stigma. And so we had to get the conversation started, and a little tagline there is join the conversation. And mental health matters is a big print. But I was so concerned that someone would be picked on being on a billboard that, and I said we had, I think we have three, that our contract was that they could take down any billboard within 24 hours of my being notified that one of our children was being teased or bullied because they were on the billboard. And I think they've been up for 2 years and we haven't had one call. So that in and of itself is a success. Thank you.
Good afternoon, everybody. Can you hear me okay? All right. I just really appreciate you, Pat and Rex, for taking your time to be here today with us. And I think we're all learning so much from the work that you guys have done over the years. And it's evident that you have made an enormous impact on the health of many communities, and especially critical access hospitals and communities that have those within them. So thank you. So I want to start out by asking you a question about kind of the individual versus the group. And we know that hospitals have an enormous impact on the health of individuals and can help, in those inpatient settings that we see less and less of. But can hospitals really truly impact the health of a community? And I'm interested in your thoughts on that.
I think I can start on that one. The first thing that struck me when you asked that is, I've just been talking about mental health, so I'll stick on that topic. If we are able to reduce the stress in a family, that just radiates out. And if we're able to take people that are stressing each other, it could be not families, but just neighbors, and show them better ways to work through problems, it's going to help the community. So I'm certain within mental health that this would really improve the health of the community. And I'll let
kind of this exponential systems impact.
Yeah.
So,
What, absolutely. I know of several cases where a local EMS system was going to fail. And they talked to the hospital, and the hospital said, absolutely, I'll take over their EMS. Now, had they not had EMS in that community, what would be the impact? I also think of, behavioral health. If you didn't have that hospital setting, without that, you won't have that connection or that access. The other thing is that you look at with population health and having physicians and nurse practitioners there providing the screenings and all those things that you catch. What a difference that makes. And if we didn't have that, we wouldn't, be able to support that. So that rural hospital keeps those providers together. They also provide that outreach in smaller communities that I talked about, just has the Casey stores. Well, they often now have, a part-time rural health clinic where they can go in and get their health care. Maybe they might have to travel otherwise 60 miles or more. And if they have an accident or, whatever. And this way they can come into the local hospital, have their blood work done and see those things so that you could just go into the depth of it. But what I think is most important today is that our hospitals are taking care, they're really looking at their community as a whole, and they're doing programs like what Rex described to improve health. I mean, hospitals always taking care of the sickness and the injury, but now it's health. And so you're seeing the growth of that and how that's going to be able to keep people locally using telehealth and other things.
Thank you for that. I hear in what you said a focus on kind of a holistic approach. And I think we see that and hear that more and more in healthcare. And so when we also transition that viewpoint to the community, there's a big impact there. You also mentioned some specific programs in reference to some of the work that Rex has done. And so Rex, I'm going to direct this question towards you. Your Healthy Hillsboro project with SIU Medicine's Department of Population Science and Policy recently won the 2022 Outstanding Rural Health Program Award from the National Rural Health Association. That is a mouthful, but I just got through that. Could you describe how Hillsboro area hospitals came up with the idea for this project, and how were the goals of that project aligned with the community's needs?
well, a real short answer is we didn't come up with the idea for the award. We don't look at awards, and that's a mistake of mine. Okay, I'll put that on the list. We do kind of keep our successes under a cover, under a blanket, I guess you could say, for a biblical reference, and that's wrong. And the PSP figured that out, and they were the ones that initiated pulling all this together because they could see the impact, and we have a view, that goes 15 miles in any direction, and it was 104 communities that Samir referred to. I think it's 66 counties. It's a tremendous geographical footprint, and they were able to see the impact of what was happening, and we kind of think it's going on elsewhere. We don't realize it. It's only us. So we didn't apply.
Well, I'm glad that Samir brought that idea to you.
Yeah.
Did.
Yes.
Where did you come up with the idea for the program, Healthy Hillsboro?
Well, that is a holistic approach, and that goes back to let's say the late 70s. I'll say the late 70s. Wellness started to get infused in subsets of our mission until it was at the top. And by 2003, we started a project with, we have 4-lane swim, 25-yard swim, play features, lazy river, etc. Half of a gym, a walking track, elevated walking track. We have a lot of facility that we built in order to have an impact on the health and welfare of our community, which is basically our mission statement. And we were looking at population health in the best way that we could when there really wasn't a lot of data and we didn't have any staff to do much work on it. And so we started from scratch, and it was homegrown. We picked up people along the way, and it was Laura Wessel from the team who came to us with a few ideas, and we were able to start stepping up our game by the people that we were associated with. And we're rural, and so I'm as humble as Pat, hopefully. And we didn't think anybody would work with us on these things, but it was outreach time, I guess, for the school. And Samir was here, and so we've just moved forward with that team of people and their support from that point. So that's where wellness came. We came up with the idea, and then it started to work. Well, you keep going with it.
Thank you for recapping that for us. Pat, with your extensive network of critical access hospitals that you work with here in Illinois, as well as your credentials nationally, what other models of success have you seen, and what are some of the maybe more unique or creative ideas that you came in contact with?
Well, I really think that our rural hospitals have really taken hold of value-based purchasing, that term of taking care of the patient locally, because care coordination is so important. You see that not only with young families, but older people about, we now have our hospitals that have what they call care coordinators. This is in larger programs too, but in the rural community, that they're making arrangements for them to get their transportation. They're developing vans to go and pick up patients. And this is just hard for some of these small communities that don't have a lot of resources. And then they're making the difference in coordinating care and getting that person to the right place. They're following up and I think that makes such a big difference. They're making phone calls to patients when they go home. We have local ambulances that are doing well check visits. And I think that's remarkable. They were in the hospital, and the hospital owns the ambulance system. And so they send the EMS people out on a downtime to go and check on that. And I think that's a great model. I can see more and more partnerships with EMS and other community groups on that well check and partnering on those community things. And I think the other thing is that what COVID did is it taught us to work together with our public health department. You know, I see the hospitals and the public health doing their vaccines together. They're doing their promotional stuff together. That's all good. And as I mentioned in my discussion, that we have, I can name two, and I think a third one is starting, where they have a mobile unit of a rural health clinic that goes to the schools and doing, you know, well checks and all those things, and the kids, that really makes a difference for that community. You know, you can look from the beginning of life to seniors, and we have to take care of our community. And it's really the anchor. The hospital's that visible part, whether it's hospital without walls or hospitals with brick building, it's that hospital setting that has those resources that they have that they can pull together to make a difference and fill those needs. So that's, it's, you know, you're seeing that all over the country. And when they started the critical access program back in the late 90s, is that they were having more and more hospital closures. I mean, I think there were probably within 2 years, like 200 hospital closures before that. And we, in Illinois, we have 52 hospitals now. Having been with the critical access program since 1999, I would guess that more than 2/3 would be closed today. So you stabilize the rural community, and they've allowed to keep health care locally so people can have access. And you can, if somebody's going to have a baby, and even though they don't have OB care, Rex has got his emergency department room open, right? And another thing is what these local communities can reach out, like he has a swimming pool at his hospital, and he invites all the second graders to come and swim there. Now, what a great thing that you can do. And it would be very hard in a big city, but they could come there and know that it's a safe place. They can learn about nutrition and all those things like that that go along with keeping healthy and swimming.
Every age group can come to the hospital to swim. Pat's referring to, we teach every second grader how to swim. So it really takes a week for the classes each. And that, you talk about making an impact on a community, that did. I do want to follow up on something else too that Pat said. She started within the concept of the critical access hospital in the late 90s. Now, I referred to quite a few decades now in healthcare, and I can assure you that every idea that Pat brought up in her presentation, there were people opposed to it. And sometimes it was me. And so I was not in favor of critical access hospitals. And
I wasn't either at first.
yeah, so
you know, we're hospital people. We're inpatient oriented, and that was really a life-switching change, right?
It was, and the
All good,
board was, and the doctors, our physicians were. So it turned into a battle. But it was, you know, when you're against something and then you change your mind, it makes it easier for you to see the other side and be able to help persuade them through the tough spots. But yeah, there's been a lot of confrontation within change in healthcare.
You look at the outpatient departments in our hospitals. Think about those outpatient departments. You know, how easy access it is to it now. What a difference that makes for our community. Had we not had critical access and the money to do that, they would have been little rooms. You know, we have had 12 new hospitals built since 1999 with our rural communities and renovated greatly like Rex has. So there's been a real positive change for rural. And what it means is that the country and people believe that it's important to have rural health care at home.
Yeah, and a thread that I'm hearing is around resources and how are we creative with our resources? And sometimes that requires change. Sometimes that requires change that ourselves and others might be resistant to. So we've just got a couple more minutes left in this session, but I'm wondering what creative resources are out there for critical access hospitals, and what have you seen are ways that critical access hospitals are able to maximize the resources they do have for greater impact?
Well, there's grant money through the Illinois Department of Public Health, Center for Rural Health, right, Kristen? We have some flex and ship dollars. Those are I call them research dollars. Rex Hillsboro's gotten those dollars over the course of time. And they help them to be creative, create new programs, probably help expand some of his wellness programs and things like that. So those are real creative. And I think you get people together and you have limited resources and you start thinking, well, we can do this. We can go out in the community. And who would ever thought that we would do home visits and hospitals without wall and mobile units. So I think there's a lot of creativity. I think using funding correctly and getting community support, that's that partnership. If you talk to the community, they say, I really would like to have that program. And lo and behold, people like Rex make it happen.
I like what you said about mobile units, and you've mentioned mobile units a couple of times now. We recently learned that, here in Springfield, we've got a mobile unit that will also go out to many of our rural communities. And so sometimes, those mobile units are so mobile that we can, help expand kind of impact by partnering even with our urban neighbors. So yeah, I think that's a really neat kind of thing that's evolving. Rex, I think you were going to make a final comment.
Yes, I will. How do you expand the potential power of your resources? You partner. Just like I said in our vision statement, we will partner with our community, and it turns out, and others. And we have a number of entities in the community that we participate with or led or financially support. And by doing that, by partnering, you're bigger. You're bigger, you can make a bigger impact. And we partnered on doing our community health needs assessment, again, through the PCP with 2 other hospitals. And now we have ways to join together on food deserts and on 2 other areas. One of them is within mental health that we wouldn't have had the resources to do. And there's more of that. No plan will be exactly like us, and we wouldn't be exactly like you if we took your plan, but you get these relationships going and you can have a bigger impact, guaranteed.
I just wanted to add that during the pandemic, we had a grant from the Illinois Children's Healthcare Foundation, and they gave money to the rural hospitals to help with daycare for their employees. And that's not a new concept, but several of them said, okay, well, let's build a daycare, but they didn't build it at their place. They might have built it at the local community center or something like that. And it's not a new concept, but the way that they could just take that little extra money and then they could partner with some other people and make it happen. And I think that was, we didn't ask for that. That was just a gift. And how you take something and use it is just really extraordinary.
Yeah. All about that collective impact.
Mm-hmm. That's your impact.
Yeah. All right, well, Rex and Pat, thank you so much for being here today. And thank you, everybody, for spending time with us this afternoon.
Thank you.
Now we got to get ready for Hana up here. I better turn things off.
It's my great pleasure to bring on board Dr. Hana Hinkle. Dr. Hana Hinkle is the director and the department head of the National Center for Rural Health Professions at the University of Illinois College of Medicine, Rockford, and has recently been appointed the Assistant Dean for Rural Health. Dr. Hinkle also serves as the executive director of the nationally scaled Rural Training Track Collaborative, which is a 72-member not-for-profit that aims to support the development and sustainability of rural residency programs across specialties. Dr. Hinkle is the president of the Illinois Public Health Association and is involved in a number of state and national groups. She has also served as the president of the Illinois Rural Health Association. In 2022, she was named as a presidential leadership scholar. Dr. Hinkle, the floor is yours.
Thank you.
Thanks so much. Hi, everybody. Thanks so much for having me, and thanks for hanging with me this afternoon post-lunch. I'm very excited to be here today with some familiar faces and to get a chance to meet those of you who I haven't had the opportunity previously. So before anybody asks, yes, those are all the things that I'm involved in. And no, I don't require a lot of sleep, but I do require a lot of coffee. So my local Starbucks kind of can gauge how much how many meetings are on my schedule based on my order, if it's a venti or a grande. And I also would not be able to do all those things without the support of my family, especially my husband, Colin, whose birthday is today. And I just had to tell him we'll celebrate at some point, but we've got to talk about rural health, my favorite topic today in Springfield. So today we'll be talking about the future of the healthcare workforce. Let's see if I can advance this slide. Oops. See what you mean, Rex. It's a little testy. Let's see if this works. Okay, so you can tell I'm a teaching faculty too, because I always have to have objectives with any discussion that we hold. So today we're going to talk again about rural health workforce education and some of the challenges that we have in recruitment and some successful strategies. And I think maybe the slide deck isn't updated from a previous one, so we'll go from there. But first of all, I don't have any disclosures except that my rural roots run really deep. So I'm pretty biased when it comes to rural. I always look at the challenges that we face in rural communities as opportunities. And that might seem cliche to some of you, but I'm deeply committed to this work because of sort of my background and upbringing. So just wanted to take a moment to share some photos. Some of you who have heard me speak before have seen this, but this is Oregon, Illinois in Ogle County. It's up north. And like many small towns, we do have a claim to fame. Ours is that we're the proud location of the second largest monolithic concrete statue in the entire world. It's right there. You can see it in the left-hand corner. So if you ever need to take a drive on a weekend up north, come to Oregon and see our statue. I usually ask students in our programs what their town's claim to fame is, and recently, sort of as like an icebreaker, but recently I had students tell me that they were from the largest popcorn distributor in the country, and then I also had a student follow up that their neighbor purchased a tiger that was featured on a popular Netflix series. And then we stopped that discussion because I didn't want to hear any more details about that. So whatever your town's claim to fame is, we support that in rural. So before we get into discussion about what rural actually is, we need to define it first. And this is a very complicated figure that was just published. I don't think the citation's coming up on the slide here. I can see it very lightly, but there's a lot of different ways that we can define and measure rural. This is important because sometimes rural definitions are tied to grant funding or how we recruit certain students to certain programs, but we've really had national discussions around what is the best definition of rural. And there's different debates in academic circles about this, and I'm sure we could have a whole session with some of the researchers on how we define rural appropriately. But I wanted to highlight that there are pros and cons to various definitions too. Some can limit the impact that you can have with your programming and recruitment, and others, are so expansive that they might qualify a place kind of where we work around Rockford as more rural, and we certainly know that that is not the case. There's too many Targets and Starbucks around there, although there are significant underserved populations, which is another demographic that we want to continue to consider in our work. But for me, beyond definitions of rural, rural is really about people, and it's about culture. And so I wanted to highlight this picture. This is of my mom, who's the youngest, pictured here, and some of her siblings. So my mom grew up as a migrant farm worker. This is her family, part of her family on a farm in rural Ohio. They moved up to Illinois because some steel mill was coming to the Sterling Rock Falls area in Whiteside County, and they were hiring migrant farm workers. So her family was able to get employment through that route. And I told my mom that I use this picture to sort of highlight why I'm so proud to be where I'm from and why
I'm so mission-centered in the work that I do in rural. And she was like, why do you show people this picture, Hana? It's embarrassing. She's like, I don't want people to see that I was poor or that this was the only dress that I had. And she's like, you know, we didn't have a lot of resources. We didn't have any money. I couldn't speak English at the time. She learned English when she was in kindergarten in Sterling, Illinois. And we had a really meaningful discussion around that because what she was sort of ashamed at is something that I'm very proud of. And we're able to come to this recognition that we can't do this work unless we understand who we're impacting. And for me, when we're talking about all of the different challenges, I look at those challenges as opportunities because this particular picture highlights the opportunities that were created to get me to where I'm at today and to get our students that we're recruiting from very similar backgrounds to be successful in the professions they've selected. So rural health workforce needs. Now, we've talked a lot about this today in the conversations that I've heard around behavioral health workforce needs and other sort of problems and challenges. And I'm sure we could all take a moment to reflect on what those individual workforce needs look like in your own organizations. But we can see more specifically about some of the hospital workforce shortages. The Center for Healthcare Quality and Payment Reform recently published a white paper that highlighted some of the closures. And I'm sure people like Pat in the audience and others could really talk specifically about the critical access hospital needs and the small and rural hospitals. Abby, I see you back there too. But at the end of the day, we know that these aren't just data points. They're actually work that needs to be completed in some way, and we need to have a workforce ready environment to help solve these challenges. We also know workforce issues create closure risk among rural hospitals too, and these are some percentages of hospitals that aren't going to close but are at risk. We know that things like sequestration and other policy reform issues have very real effects on our local communities. And that was really well articulated by Rex and Pat in your discussion as well, how impactful that rural hospital is to a community at large. To address some of these workforce issues that we see, the National Center for Rural Health Professions at the University of Illinois College of Medicine in Rockford has uniquely positioned ourselves to address these challenges from an education perspective, a policy perspective, and a little bit in translational research. I'm highlighting some of our programs that we'll talk more specifically about in a little bit, but ultimately our focus is on education and developing communities to develop their own future workforce one day. So we've all sort of heard the concept of pipeline programs. And you might be thinking, I thought this was talking about the future of rural health workforce, and we're talking about things that have been in existence for decades previous to now. But we are very proud to be in a brand new funding cycle of the HRSA-funded Area Health Education Center Network Program. This program was established actually in 1972. And it was really initially established to sort of create opportunities and awareness for underserved rural and underserved urban students to have some sort of meaningful impact. Now, this new generation of AHEC funding is really helping us to establish some mentorship opportunities for students who have tracked themselves into a health professions program. And we want to make sure that we don't lose those students who have already committed themselves to working in a healthcare profession for other sort of opportunities outside of a rural underserved environment. Our goal now is really to improve healthcare for underserved by increasing access to learning and professional development opportunities and really promoting health careers development. We also do a lot of work with our critical access hospitals to help provide some continuing education and other support because we know that rural healthcare delivery can sometimes feel pretty isolated. And so we're trying to create those networks of connectivity among practicing healthcare professionals. And to give you a sense of some of the recent updates and activities we've done, I wanted to play this video. Let's see. Here we go.
Of AHEC is to recruit and retain a diverse workforce when it comes to medicine and healthcare.
training health profession students to really go back and practice to the areas that need them the most. We have 9 total regional centers that serve both underserved urban communities and underserved rural communities.
Getting out within those communities and finding out what the needs are and how we can assist them is a part of what we do as an AHEC center.
The Illinois AHEC Network has developed a number of programs to increase the awareness and interest and excitement around students pursuing a career in the health professions. It's incredibly important to get students interested in health careers as early as possible.
Being a part of AHEC Scholars definitely opens the doors to various possibilities in healthcare.
AHEC Scholarship is a really innovative program. It's really aimed to increase awareness and understanding of different issues that impact health status and health outcomes for underserved rural and underserved urban populations.
You get to network with industry professionals. If you want to become a medical doctor, chances are you have access to them when you are an AHEC scholar.
We also have a program called the Rural Health Experience, which is a 3 to 5 day program aimed at getting students into communities and really understanding those unique needs. They get to talk to hospital CEOs in these areas. They get to talk to local health department administrators and other practicing health professionals to really understand the challenges and successes that they can experience in that profession one day. Our 6-week summer interprofessional preceptorship program. It has a lot of really innovative components where students can actually work in a community setting, develop a community service learning project with students who are outside of their own discipline.
The preceptorship was really rewarding because I was able to work with other healthcare professionals. I was able to really interact with just about everybody on the healthcare team.
These AHEC experiences set them apart from other students because it gives them a well-rounded education.
I was able to use the skills that I learned through my preceptorship right away here at RMed. Getting to see all this public health data beforehand through my preceptorship really did set me apart from my peers.
Students are able to see hands-on, in-depth, and have experiential opportunities beyond just the classroom. They get to get a sense of the culture and the needs of the community, and they form that relationship with those employers early on so that once they're ready to graduate and ready to pursue a position somewhere, they already have a network built.
Really meeting people where they're at is so critical, especially in our rural and underserved areas.
It's all about student mentorship and developing those relationships early on with students so that they know that there's support throughout their educational pathway.
For practicing professionals, we partner throughout the region to provide different training opportunities that would help them clinically within the region.
This interaction of all of the healthcare team that I was able to see during my rural health experience, it has reaffirmed for me that I want to practice in a rural setting, specifically a rural hospital. I knew that I wanted to be a part of that in the future.
Healthcare professionals are natural leaders in their community, so we want them to be able to step into that role when they finish their education.
You don't have to necessarily start out with all the resources in front of you. You can build networks and you can build connections and really find your path and make a difference in the long term.
You may find a new passion.
Can you exit out? I don't want to. Okay, thanks. So you can see that we have various training opportunities for students, and we can work with community partners to really customize the amount of resources, whether it's staff resources or housing needs to host students at your facility. And we found that this is a really impactful opportunity for students once they connect with local hospitals and local health departments as well, to do career exploration, but also a way for these partners to be able to ultimately recruit and sell the location for a future employment or future practice location. So we do, as I mentioned, and as you saw in the video, we have 3 to 5 day experiences. We have an entire summer, basically internship experience. We also offer things like camps, which have been done, for decades, but we're sort of recognizing the fact that we need to transition a little bit about our approach to fully engage students who participate in like those 1 day, more sort of unstructured activities. So we're creating institutes for students who are part of our camp opportunities in the summer, so they can come to our campus or a local campus and get sort of additional training outside of what their experience is in the camp format. So we're really creating these more robust mentorship opportunities for students. When we talk about mentorship, it's particularly with the AHEC network, we're also talking about encouraging students to think about stackable credentials. So we are realistic in the fact that there's social and structural and systematic determinants that create barriers for success and development for students, particularly from rural and underserved communities. And so because of that recognition, we want to make sure that we're working with students and meeting them where they're at and where their families are at as well. We also got funding recently to do a Salud Scholars program, which I'm really excited about, kind of leaning back to my roots working with Spanish-speaking populations and migrant health populations. This programming is going to allow us to work with underrepresented minority students and their families, again, kind of working with that cultural dynamic a little bit too, and creating education not just for the student, but for their families as well. We have something called an Academia de Padres, just for parents, who will be able to learn from a Spanish-speaking instructor about the different pathways their student could take. So another sort of case study example for health professions education is, are you controlling it or, okay, thanks. This Illinois RMed program. And I'm highlighting RMed because it's our program through the College of Medicine in Rockford, but just as a case study. I'm fully transparent in the fact that there's no one program, I should say, working in rural medical education that's going to be able to solve all the workforce challenges we have in medicine. And so I know that there's really innovative stuff happening with SIU and the Lincoln Scholars Program and some others across the country that are very mission driven to create opportunities for rural background students to be successful in medicine. So RMed started in 1993, and we have continued to innovate and evolve around the curriculum that we provide for our students. We have an innovative admissions process, which is really focused on identifying social accountability. Has anybody heard that term before? Okay, a few people. Social accountability is a great measure for us of how committed a student is going to be to return back to a community similar to where they're from. We're looking for how active they've been in their community, how much they've volunteered in the past, sort of a measure of altruism in a way, where we can make sure that students are going into rural medicine in particular, understanding and recognizing the significant challenges and needs that they'll be faced with once they become practicing physicians. The profile of our RMed students look a little bit different from 1993. So on the right here, you can see traditional rural scene, cornfields, and on the left, my left, it's looking a little bit more, we see some sunflowers, but it's a little bit more suburban. And so we recognize that the students that we're admitting into our RMed program have variability in the type of rural background where they're from. We're not talking about students who all come from agricultural production backgrounds. And we probably have less and less of those students. But we have students who are still very committed to their community, but that community landscape might look a little bit different. And so we have to start integrating different training ideas into our curriculum so that they can be responsive to the different needs that we see across rural communities. So our curriculum is longitudinal and interprofessional, which is incredibly important to us because we want to create the next generation of leaders in rural communities who can work on a team-based care environment successfully. We have a multi-specialty clerkship. So we have somebody in our office, Diane Potts, who I think is listening virtually. She does an incredible job of outreach and networking to create opportunities in the third year of training for students so that they can do a little bit more with career exploration. Why do you think this is important? It's important because by the time they get to their fourth year, students have already kind of committed to the specialty and discipline that they want to train in. And so we want to make sure that we're providing opportunities for students to really understand these are the specialties that motivate and drive me to want to make a difference. We also have our 16-week family medicine immersion experience, where students do also participate in a community-oriented primary care project, which is a research project in a sense. It is scholarly activity, but it also has some translational benefit back to the community. So we teach students research skills starting in their third year, and then they have an application process to really make a difference in the community setting. So we work to identify those challenges and their particular rural community. And here again is a map of all of our sites. We also have some innovative training content around recognizing some of the population health needs. This is our No Harm on the Farm series that educates students on farm safety risk. The Illinois Farm Bureau was an incredible sponsor for us to bring our students to 2 dairy farms. We've been doing this for 16 years, but again, have sort of changed the delivery model a little bit to recognize some of the emerging issues around emergency response in rural communities. This happened on October 14th of this month, and then just this week, we got news that there was a grain bin death that happened in a community just south of Rockford in a rural town. So these are real world experiences that these students are practicing for in the future. And it serves a critical need. And if anything, it creates awareness for students that they can recognize some of the challenges in responding to these issues. It's also really interesting because the dairy farmers that host us for this event share with the students about their own struggles with mental health or creating access to mental health services and some of the resistance that just farmers from a population perspective might have when they interact with the student once they're a practicing physician. So they provide some, I think, really important content to students too. And then I just had to show you a picture of the new baby cows that were on the farm, who were a big hit too. We also offer students a chance to train with the Eastern Shoshone and Northern Arapaho tribes in Wind River Reservation, Wyoming. Now you might think, what's an Illinois medical school doing with training sites in Wyoming? But there was a grant that we had many years ago that supported an opportunity to work with Native American populations. And this site in particular has been one that we've been able to continue to develop our programming. So we have 2 students out there right now completing their 16-week family medicine immersion experience, and then they also get to do their research project. So one student's really focusing on the mental health needs of Native populations, and another one is looking at how we educate parents to look for sort of warning signs for their adolescents. So this is, again, an important training aspect for us. We can't send every student, obviously, to this tribal community to train at, but it's an opportunity for students to see rural healthcare delivery in a new and different way, and we hope that that can sort of spark their understanding of some of the other significant issues in other populations in rural. Just to highlight our outcomes, again, we're really strongly focused on admitting students who come from a rural background and through various metrics can demonstrate a level of social accountability and sort of mission-centered medicine. We've also done studies that I'll probably highlight here in a little bit that were spearheaded by Dr. Martin McDowell. He was a longtime faculty for us, and he identified that one of the most significant indicators of rural practice is a rural background. So again, we are using data to sort of drive our decision-making about the admissions criteria for a program. We have over 400 students graduate, which we're incredibly proud of. We started out with only 15 students per class, and now about half the class of each medical school class at Rockford are rural students taking this supplemental curriculum. We have about 58% of our students practicing in Illinois, and 2/3 of those are practicing in downstate communities. So we don't have very many. We only have 3 students that are practicing in Cook County, and that's not even Chicago, that's the Cook County itself. And only 7 graduates are practicing in a large city environment of 150,000 plus or more. We're also working in terms of innovations and future health workforce development on making sure that our students or any students who graduate from a rural medical training, undergraduate medical education program have the opportunity to then go on and train in rural training tracks. These are tracks that are federally funded, federally supported. They're now being named rural pathway programs. And we're really pleased to say that in early 2022, we acquired the Rural Training Track Collaborative, which has 72 of these rural pathway programs, primarily focused in family medicine, but we're building our network of rural GME programs to focus on psychiatry and meeting the needs of other disciplines in rural communities too. So now we have a direct pathway for students from rural programs on the undergraduate side to go into GME opportunities that are focused in rural. So these are just highlighting some of the locations of our partnering GME programs. Again, this is not just University of Illinois specific. This is an opportunity for all students who are trained or have a rural interest to continue their graduate medical education training in other areas. And it's really important because I think historically, especially for RMed, we had these incredible students who are deeply committed to serving rural populations. But when it came then to figuring out where they went on for training after they graduated medical school, we're kind of like, you can pick wherever you want to go, which is largely academic medical institutions, which is great, but data is also showing that it really depends where students go to residency, where they end up practicing. So we want to create other opportunities for students to support their rural interest. So additional strategies for us include creating accessibility of learning environments to equalize rural education disparities. So this is something that was critically highlighted for us during the COVID-19 pandemic. So all of our pipeline work is very much resource intensive. You have to be in front of the students. You have to create experiences for students in person or within a community setting. And COVID just didn't allow us to do that, obviously. So we have been partnering with OSF and their Jump Simulation Center to help digitize some of the content. We're creating apps now of some of the handbooks and resources that we used to have to print for paper. This also helps for sustainability purposes because, again, we have this very important grant from HRSA to fund some of this work, but we recognize the fact that federal funding is sometimes not always reliable. And so we're trying to, again, create diversified opportunities for sustainability for the work that we do. We're also trying to develop resources from a community academic partnership perspective, seeing what local hospitals' needs are, and then we can help match those needs with our own resources and experience. And then really just continuing to innovate training opportunities to engage a new generation of learners. I mentioned the type of students that we're recruiting into RMed right now are a little bit different than what they looked like 20 years ago, just from their background and experiences and interest. And so we're reviewing our curriculum to make sure we're including things like telehealth and how we address the opioid issue and other things like that. So that's my presentation. Happy to take questions. Yeah.
Does your program focus on, just students out of college, or do you open the door to students that are in their late 30s, early 40s that want to go into medicine?
Yeah.
What's your variability of your type of class?
That's great. That's a great question. We typically admit a few non-traditional students out of the 27 to 30 students that we can accept at various levels of training and background. Primarily, we have more traditional medical students apply, but we also have students who maybe need a little bit more development academically, so that they pursued a master's degree before applying to medical school, and they've been accepted that way too.
Getting questions from people so that's not too bad. I just wondered if you wanted to talk a little bit about the other rural programs you guys have, like nursing and all of that as well.
Yeah, absolutely, Abby, thanks. So I'll go back to this slide that sort of highlights all the different logos and partnerships that we have. So we started building this interprofessional longitudinal curriculum with our College of Pharmacy, and so they created our farm, I think pun intended, pharmacy program, and that recruits students who are interested to practice rural pharmacy. So those students train with our medical students across all 4 years and do collaborative projects in their 16 or 18-week experience that pharmacy students are required to do. I will also say, though, it is very challenging to run a true interprofessional collaborative program if you don't have equal numbers or close to equal numbers of students. So right now, We have a lot of RMed students, which we love to see, but we have an underrepresentation of pharmacy students. And so this is where it's really, really nice that we have our AHEC partners across the state who can also help us identify students who may not know what exactly a rural pharmacist does, but creates those awareness opportunities for students and can help feed into our pipeline programs. So we see on average about 40 to 50% of the students we admit to RMed have some type of experience with those pipeline programs. And so it's a long sort of pathway to get students onboarded into that way, but we know that when we can mentor those students appropriately, they're able to come and pursue their passions in the rural health professions. We've also tried to partner with rural nursing. Again, a lot of this comes down to logistics of scheduling. Our rural nursing students are actually DNP level students who are also practicing. So then you have students who, are undergraduate medical education students paired with rural pharmacy students, paired with practicing nurses in the field. Logistics can be complicated with that, but we continue to try to innovate around how we best bring those different disciplines together.
I was listening to WGN over lunch hour a couple of weeks ago, and they had somebody on that was talking about workforce. And this surprised me that after COVID, they said women are not, that more women are not returning to the workforce, or if they do, they have very limited, they have very specific goals that they want to achieve when they come back to the workforce. I was sharing that with a couple of CEOs on a call, and they were saying, and one CEO said, yeah, my daughter, she's a surgical nurse at a small rural hospital. She now can work in the OR 1 week on and 1 week off. You would never, ever do that years ago. But it lends us to looking at when we build pipelines and as people that have, hospitals or clinics and bring in the workforce, and what are some other strategies that we can use to be creative? I think, people don't come in and start a nursing, whereas Heather's daughter is a new nurse. And I said, she was telling me where she was going to start. I said, usually you start at 11 to 7, the night shift in the back of the hospital, but nurses, don't do that, nor pharmacists or physicians. It's, a change in the work style type work-life balance. So do you want to share any ideas you might have on that?
Yeah, I mean, it is definitely another sort of challenge, I think, to recognize particularly the gender disparities that we're seeing. And I think, we haven't necessarily studied this very robustly, but what I think is, again, another opportunity for us to see how can we take the model of like that stackable credential, building up skills, building up capacity to go on to the next step and apply that to the active workforce. So I think the example you provided, Pat, of hospitals sort of being creative with shifts or allowing some flexibility or a flexible work schedule. There is a crisis happening in a lot of different disciplines in rural health workforce shortage areas. And whatever we need to do to sort of balance that out by being creative and sort of think out of the box for current employers or I think, is worth trying. I hear a lot of feedback that says this is great that you're doing, all these different programs across all these different disciplines and you're, creating these pipelines and pathways for students who might not necessarily have opportunities to be successful in the health professions, but I need nurses now. So what can you do now? And I don't think that's necessarily our policy to change, but I think it's something that we can certainly collaborate with their hospital partners to figure out, what changes can be made to make things more accessible and more appealing for people to come back to the workforce, knowing that we have to balance out a lot of different factors for other reasons too, post-pandemic.
Dr. Hinkle, we had a question from the chat.
Yeah.
Are there any healthcare professions that you notice are thriving or growing recently?
Everybody loves public health, which I like to see with my background in public health. I think there's some people categorize the Fauci effect post-pandemic and seeing people sort of in the field responding day to day. We're all about public health workers, but we also have to develop the public health workforce to be able to attract and retain formally trained public health practitioners. So we still have, I think, particularly in rural local health departments, an issue where they might not have sort of the salary capacity to support somebody who went to school an extra 2 years to get their MPH. So that's sort of a policy perspective too. Also, we have a lot of momentum going on in the state, which I love to see with community health workers. And I think we've been talking a little bit too about some of the challenges with reimbursement strategies. That's all at a policy level. And so that's a challenge I would put back to on the audience and the people who are listening to make sure that you're using your voice to elevate and information share those critical needs that you have within your organizations and communities to make sure that there's support and infrastructure available to people who are very much excited about working in disciplines like public health workers or community health workers. Great. I'm happy to chat offline if you have any additional questions, and thanks so much for your time.
Thank you, Dr. Hinkle. At this point, we'd like to take a break and we want to restart our session at 3. So stay tuned and see you back then. Thank you.
I'm just gonna use this. I just, maybe